So this week we're going to start our lecture on the cardiac cycle, which involves a few phases we have to be familiar with as a cardiac sonographer in order to properly perform our function of interpreting what's going on in the heart for the echo reader. This is if you want to watch this online, I post this kind of just gives you an idea of what's happening through each phase, and this is for your review purposes only. I believe it was Carolyn that asked that I post these videos outside of class too, so that you can review these, and that's fine. I don't mind doing that at all. Anything for you guys. So basically, the cardiac cycle involves either diastole or systole of either the ventricles or the atria, and there are some what we call periods of time in there where the heart's either almost at stasis, either iso-relaxation or iso-contraction, so to speak. So when iso means just stagnant, not moving at all. And those periods are very, very brief. And we're going to discuss the whole cycle here as we go. There are 7 phases to the cardiac cycle. We have atrial contraction, the first phase, isovolumic contraction, number 2, number 3, the ejection phase, rapid ejection we would call that, number 4, reduced ejection phase, number 5, isovolumic relaxation. There are 2 of those isovolumic periods. Number 6, rapid filling, and number 7, reduced filling. And we're going to discuss each and every one of those. And I want you to refer back to this illustration here as you look through these this video in particular anyway. We're going to use this illustration diagram, if you will, to illustrate, as I explain what's going on, what basically you look at the X and Y axes here, and you'll see that pressure is up here, and we're talking about ventricular and atrial pressures during the cardiac cycle, as well as volumes primarily related to the ventricular volume here, not so much the atrial volume, which is the ventricular volume, of course, is what is pumped out to that portion of that volume is pumped out to the systemic circulation in order to perfuse the muscles that we need and the organs that we need with blood and oxygen and their nutrients and so on and so forth. Down here you see the electrocardiogram. Everything is shown in conjunction with when we are either in our cardiac cycle systole or relaxation phase, either systole, diastole, so on and so forth. And don't pay too much mind to this here. These are the sounds that the doctors listen for, physicians do when we have, these are the sounds of the valves opening and closing and during these pressure changes within the heart. So we have that, we have the ventricular volume, and speaking of pressure, we have the ventricular pressure here. That's the blue line here. We can follow that along with our cardiac cycle and our cycles up here. And we also have the atrial pressure in here that we can follow along. And also the aortic pressure right here, as you can see in the red here. So you have when the mitral valve opens, the aortic valve opens, and so on and so forth. So we'll keep referring back to this as we go through our phase cycles. It looks like a pretty busy diagram, of course, but once we go through this, I think you'll grasp it fairly well. So the first phase, as I said, is atrial contraction, phase 1. And that's when the atria are going to be squeezing, of course, and they're going to be pushing blood down into the ventricles. So during atrial contraction in phase 1, the mitral valve and the tricuspid valves open, and those are right here, our atrioventricular valves will open and allow blood to flow down from each atria into either the RV or the LV, and our aortic valve and pulmonic valve or our semilunar valves will be closed during that period of time. That's atrial contraction. So the P wave of the electrocardiogram equals atrial depolarization. So if you look back here and we look on our echocardiogram, we see our P wave over here. That's going to represent, as we just said here, atrial depolarization. And when the atrial pressure exceeds ventricular pressure, our atrioventricular valves will open and blood will rapidly fill both sides of the heart, the RV or the LV. In a young, healthy heart, as most hearts are in our class, young and healthy, most people are, you're going to see this phase is going to happen very rapidly, and it almost creates it does in a young 20-year-old heart or so. There's really a suction phase. It really sucks the blood right in there. And when we talk about diastolic filling of the heart, which is what this is, and when we get into discussing diastology and how we evaluate that, the diastolic function of the heart, which happens during the filling phase, we'll go into more detail of how the blood rushes in to a young heart as opposed to when a heart gets a little older and the atria kind of kick in and take over for that filling that doesn't happen as well as it should when the heart kind of gets stiff as we get older, so to speak. So atrial contraction does cause a small increase in venous pressure that can be seen as the A wave of left ventricular pressure. So basically what they're talking about there is that if you look at the cath lab and the waves that they measure, Lisa's probably talked about this in the class, she teaches, and there is a little bit of back pressure into the pulmonary veins when the atria contract. Because remember, the atria contracted the LA into the pulmonary veins, fill the LA, you get four of them coming in here. And a little atrial pressure contracting right here will push a little bit of pressure back that way and cause a little curvature in the cath waves when we measure in the cath lab. Okay, so that's where we left off there. So I'm going to, once again, just show this thing here where we're these different phases. So we're in atrial contraction right now, right? So that's going to be atrial systole right here. And we're going to go from there and swing right back to here on our graph, because now we're going to go to isovolumic contraction, phase 2. This breaks it down to like 6 phases, right? And we've got an additional phase in there for our purposes, so let's not get too confused by that. Don't worry about that. We're talking about let me go back and see where that is. Right here. So we're talking about 7 phases: atrial contraction, isovolumic contraction, rapid ejection, reduced ejection. And here they'll have ejection. So they don't break ejection down into the rapid or reduced, okay? But it does actually reduce, because you get rapid ejection right here, and then you have sort of a reduced ejection as it crosses over here. So that's what they're talking about. I don't want that to confuse you. So isovolumic contraction would be phase 2. All valves are closed. So for these phases, as far as like when the valves are open, when the valves are closed during isovolumic contraction, atrial contraction, so on and so forth, I think that's going to be fair game for the test, right? So I'll take one of these images or put a question up, whatever, and ask you when valves are closed, when they're open, and so on and so forth. So in phase 2, during isovolumic contraction, all valves are closed. All of them are closed. And this is a very brief period of time. And if you look down here, isovolumic contraction is during this phase right here. This solid line here is when everything closes, and here you have isovolumic contraction until the aortic valve opens. You can see this phase right through here, and it aligns with this on the EKG, and it all has to do with volume and pressure changes, and we're going to discuss that. So you can see right here when during isovolumic contraction, the heart is essentially doing nothing for milliseconds of time, and then when it does contract, and the QRS complex is the phase of contraction, and isovolumic contraction is over, the blood's going to eject. The volume of blood is pretty high in the heart right here, right? It's 130 mLs, roughly cc's. It's going to eject a certain portion of that, and then you've got rapid ejection and reduced ejection happening during this period, and you can see where the blood volume goes down during that period. And then we enter back into isovolumic relaxation, which we're going to talk about in just a minute, but let's just stick with this one for a minute here. So all valves are closed during isovolumic contraction. Begins with the QRS complex, that is ventricular depolarization, as we just demonstrated. This triggers excitation, contraction, coupling of myocyte contraction, and a rapid increase in ventricular pressure happens. How fast pressure rises is determined by the rate of muscle fiber contraction. So if you have a young, healthy heart, that's going to happen very quickly. If you have an old, tired heart, it's not going to be so fast. And the maximal pressure is referred to as the pressure over time, dP over dt. That's something we'll be talking more about when we talk about diastole and systole. Well, actually, systolic function of the heart, and how we evaluate that for the doctor. So don't worry too much about that. But if we go back here, we got the ejection phase, we got the QRS complex, everything they're talking about here during the rapid ejection phase, and the aortic valve opens, mitral valve is going to close, obviously, and the pressure is going to change in there. You can see the volume, as I mentioned before, is going down because it's pumping that blood out. And you can see the atrial pressure here, or the ventricular pressure. Let's look at the ventricular pressure first. Ventricular pressure is going to rise rapidly from basically 0 in a really well relaxing ventricle. It's going to be higher in that in a ventricle that isn't relaxing well. Let's pretend this is a young, healthy heart for argumentative points, but that's going to go, pressure is going to rise, as you can see, rapidly, and go up to, in this person here, or this illustration, 120 millimeters of mercury is what's going to be generated. And this is going to happen very rapidly. The aortic valve is going to open due to that pressure rise. Ejection is going to happen. And then we're going to go back to the isovolumic relaxation phase in just a second here. So during isovolumic contraction, the mitral valve and tricuspid valves close when ventricular pressure exceeds atrial pressure, and we can see that happen right here. They're going to close here when ventricular pressure, this blue line, exceeds atrial pressure, this yellow line. That's when the mitral valve and the tricuspid valve are going to close. Ventricular contraction engages the papillary muscles and chordae, tendonae attached to the valve leaflets. Tension on the atrioventricular valve leaflets prevents them from bulging back into the atrium, becoming incompetent. And closure of the aortic valve results in the first heart sound, S1. They probably have that up here. It's right here. First heart sound would be right here. Closure of the aortic valve, open and close. Excuse me, first sound be right in here somewhere, I guess is what they're saying here. We don't have to worry about this phonogram stuff, okay? So don't get confused about that. That's not even on our radar. Just concentrate on these lines and information up here, and I'll do my best to try and ignore this stuff down here for you, because I'm just confuse everybody and myself primarily. After the mitral valve and tricuspid valve close, and before the aortic and pulmonic valves open, ventricular pressure rises rapidly without a change in volume. during the isovolumic contraction period because all the valves are closed. And once again, we said isovolumic contractions right here. That's when the pressure in the ventricle is going to rise very rapidly. You can see that happening with ventricular pressure in the blue line right here. If you go over here and look at this pressure scale, you can see the pressure rising very rapidly during that isovolumic contraction period right there. And therefore contraction is said to be isovolumic. Then we go to the ejection phase, which we're calling the rapid ejection phase for our purposes, which is going to be phase 3. And that begins when the intraventricular, intra means within, pressures exceed aorta and pulmonary artery pressures, causing the aortic and pulmonic valves to open. And once again, you can see the aortic valve opens right here with this pressure rise within the ventricle. I know it's not showing the pulmonic valve here, but that's going to open at the same time as the aortic valve. And you're going to get that ejection either through the systemic circulation or the pulmonic valve to the lungs. And of course, the pressure on the other side is not going to be 120 millimeters of mercury on the right side of the heart. It's going to be much lower in the 20-25 range. So again, isovolumic contraction. So during rapid ejection, aortic and pulmonic valves open, mitral valve, tricuspid valves close. And here's the blood being ejected out, either through the aorta or through the pulmonary artery to the lungs. So the left atrial pressure declines as the atrial base is pulled downward, expanding its chamber. So when the heart contracts, it twists, pulls downward. It's probably good to know that the heart at the base is attached. The atria is attached. It doesn't move. What moves is the base of the heart. So the base comes downward during contraction, and the base relaxes during diastole. The base of the heart moves. Blood continues to flow into the atria via respective venous inflow tracts, and atrial pressures begin to rise. So the blood is always flowing into the atria, either through these sources, the vena cava or the coronary sinus, thespian valve, is a trapezian valve we said, or the pulmonary veins. It's always going to be flowing through here. That process is always taking place. It is affected by the pressure changes, though, as this cycle takes place. The reduced ejection phase, or what we call phase 4, so milliseconds after ventricular contraction, ventricular repolarization occurs, the T wave. This causes ventricular muscle tension to slow and pressure to decline, reducing the rate of ejection. And we've seen that right here, where it's starting to decline a little bit here, was in this phase right here. We haven't entered this reduced ejection. We haven't entered the isolate relaxation phase yet, but we're getting there. Ventricular pressure falls slightly below the outflow tract pressure. However, flow still occurs due to kinetic energy of the blood. Atrial pressures gradually rise due to continued venous return from the lungs and systemic circulation. So in the atria, the blood is always coming in. It's never stopping during these phases. And you can see it coming in there, as I said. So after reduced ejection, we come to isovolumic relaxation. When the ventricular pressures fall below the atrial pressures, the AV and PV, aortic valve, pulmonic valve, close. The aortic valve actually does that first, causing the second heart sound. The beginning of isovolumic relaxation happens. Although ventricular pressures decrease during this phase, volumes do not change because all valves are closed. The volume of blood remaining, or the end-systolic volume in the left ventricle is called the end-systolic volume, I should say, or the end-systolic volume of the right ventricle. The difference between the end-diastolic volume and the end-systolic volume represents the stroke volume. So, if we look at our chart here, once again, let's see if I can just checking something here. So in this particular diagram here, we'll go over here, this is isovolumic relaxation happened right here. We were just discussing this, right? And so you can see during contraction, the volume of blood, the volume of blood has gone from 130 mLs down to about 50 mLs. So if you're talking, that's going to be 130, or if it's gone down 130 to 50, it's like a 70 milliliter change. So the stroke volume during this ejection phase was about 70 mLs, 70, 75. And if you take 130 minus 50, you get about 70, 80, 90, 100, 10, 20, 70. Divide that by 30, and you get about a 58 to 60% ejection of the blood. 58% of the ejection of the blood would happen during that phase. And that's a normal ejection fraction, say around greater than 55% of the blood. So again, 130 minus 50 is 70. If you take 70 divided by 130, you get the percent of blood that was ejected, amount of blood that was rejected, and percent of blood if you divide it. So about 70 mLs, about 58% of the blood went out. That's a normal LV volume ejection fraction. And that's referred to, that amount that went out, that's 70 mLs, is referred to as the stroke volume. So if you go back here, the difference between 130 and 50 is the stroke volume. Then isovolumic relaxation starts. The left atrial pressure continues to rise because of venous return from the lungs. Remember the atria constantly being filled. The peak LA pressure at the end of this phase is termed the V wave if you're looking at it from a cath perspective. Isovolumic relaxation, all valves are closed. Pressure's decreasing with all valves closed. You see the pressure arrows going down here. And as that pressure decreases in the ventricles and that pressure increases in the atria because of the venous return of blood here and here, the next phase is rapid filling. And if we go back to our chart, you can see isovolumic relaxation here. During these two lines here, the aortic valve closes, mitral valve opens, and we get the rapid filling phase right here. And you can see that the atrial pressure is greater. Look at the atrial pressure right here. Follow this line over. During the rapid filling phase is greater than the left ventricular pressure. end diastolic pressure in the left ventricle, and that helps fill that ventricle. And that's all depending upon how well the heart muscle relaxes. During rapid filling, as the ventricles continue to relax, their pressures fall below atrial pressures. When this occurs, the mitral valve and tricuspid valves rapidly open and passive filling begins. When ventricles are completely relaxed, pressures will slowly rise as atrial blood continues to flow in. Mitral valve opening causes a rapid fall in left atrial pressure. All that blood's being dumped into the left ventricle. Peak LA pressure creates what's called the V wave. Again, if you're looking at the cath wave during a cath procedure in the heart, you're measuring pressures within the chambers. This is followed by the Y descent of the LA pressure, again, a cath measurement. A similar wave and descent are found in the right atrium and in the jugular vein. So rapid filling, semilunar valves open, excuse me, semilunar valves closed, I'm sorry about that. Atrioventricular valves are open. You can see the atrioventricular valves are the mitral and tricuspid, respectively, and you can see the pressure in the atria has exceeded that, and they're going to open up and fill. Here, rapid filling happens. And you can see rapid inflow right here. It's going to fill very, very quickly. And then we hit the reduced filling, which is phase 7. And during reduced filling, as the ventricles continue to fill and expand, they become less compliant as the blood fills the ventricles, obviously, and so the pressure is going to decrease in that ventricle because it's filled with blood now. Excuse me, as the pressure rises in that ventricle because it's filled with blood now, and therefore this pressure increase in the ventricle reduces the pressure between the ventricle and the atria across the atrioventricular valve so that the rate of filling falls late in diastole. And you can see the rate of filling falls late in diastole. We got a rapid filling phase here, and then the filling just kind of peters out, right? You see the ventricular volume going up during diastole here. You got the rapid inflow here. Then you got diastasis, referring to right here. Rapid inflow during this phase right here. Diastasis, the flow is kind of, the atrial pressure is increasing there, right? And then we got the volume continues to rise here. Let me go back into the atrial systole here and go back through our process all over again. As the limit contractions, so on and so forth. Basically, reduced filling is going to be the diastasis phase. As the ventricles continue to fill and expand, they become less compliant, as I said. This pressure increase reduces the pressure gradient across the aortic valve so that the rate of filling falls late in diastole, as we just said. Reduced filling, phase 7. And the AV valves are still open, but the pressure, is arising in the ventricles, and therefore they're not going to, and then we're just going to go and cycle right around again. The cycle is going to begin all over again, ischemic contraction, and so on and so forth. So I know this is a busy screen, but just pay attention, if you will, to the pressures, the volumes, and when the valves open and close. We're going to discuss this in class, of course. I'll go over this in more detail. You may have questions at that point in time, and we'll try to do, answer any questions you have in class. But I hope this has been helpful to have this up here. Whoops, sorry about that. It's going to be messed up on you. So that you can review this. Okay? Thank you, guys. I'll see you on Tuesday.